Good morning, and how are you guys doing today? Welcome to Monday, the beginning of another week. You guys have finished basically a lot of the information on humidity, and so today, excuse me, we're going to talk a little bit about aerosols and what are aerosols and how do we use them. A lot of the stuff that we do are aerosols or aerosol generators, and we're going to talk about how do you administer treatments with aerosols and how do we take care of our patients with them. So the first thing is a definition. Aerosol is something you can see. It is something you can feel. If you see fog in the morning, you'll see an aerosol. If you have animals, and especially cats that are sitting there on the windowsill, and when they're looking at the windowsill, if you look at the sun coming in, you see floating particles. Those are aerosol particles. And so aerosols are things that we can see and that we can touch. The definition of this is suspension of particulate matter in a gas. Doesn't necessarily have to be water, but we can, like I said, see it, count it, and we have to count when we're talking about our medications. It can be dust, fumes, smoke, mist, whatever it happens to be at that time, but it's something you can see. If you remember with humidity, humidity is invisible. It's a vapor. It's something that we feel. So why do we use aerosols? Well, for one reason, we use what we call bland aerosol. This is just your sterile water. And we can use sterile water as a humidifier. We can use sterile water to be able to do other things that we do with our patients. We also use aerosols for medications. People have a tendency not to realize that your metered dose inhalers, your dry powdered inhalers, the rest mat, which is the new soft mist inhalers, these all produce aerosols. Some people are going to tell you, no, the only aerosol generator is the small volume nebulizer, and that's not true. It is all of those aerosol producing devices. And so remember, humidity is produced by humidifiers, aerosols are produced by nebulizers. And this is just a representation of what can aerosol do. And if you can see here, here's a volcano that erupts. If you remember way back when Mount St. Helens erupted, and when it did, it threw a lot of ash and particles into the air. When it did, it was these particles were seen from miles and miles away, and we actually had a slight change of the environment. So whenever we throw things into the environment, it will make a change on it at that particular point. So there's various categories of aerosols, the three broad categories that we talk about, and it comes from the AARC clinical practice guidelines. One of them is a delivery of a bland aerosol. This is your normal saline, or this could be your sterile water at this particular point. There's different reasons why we deliver these in order to help our patients. We can deliver an aerosol to the upper airway. The aerosol we can deliver is going to take care of some of the issues or concerns we have with our upper airway. It can also be a medication. If you remember in pharmacology, we talked about the bronchodilators. We said the big daddy rabbit of the bronchodilators was epinephrine. Epinephrine works both in the upper airway as well as in the lungs and also with the heart. The last one is the delivery of medication. This medication, again, upper airway, lower airways, is an aerosol. And if you look at the bottom there, you see two pictures of people doing aerosols. And if you notice, they're doing metered dose inhalers, and they're putting the metered dose inhaler in their mouth to be able to take this medication. This is quite a bit of change from what we used to teach folks in the back practice before. We used to tell patients that you didn't want to put the inhaler in your mouth. We're going to talk about, losing some of the medication on the back of your throat or the back of your airway. And so we would teach them how to do it without putting it in their mouth. Also, we would teach them how to do it with what we called a spacer or a holding chamber, two different devices that we still recommend. Since we had to change the carrier gases for some of our aerosol medications, the new carrier gases really don't have the oomph behind them as the CFCs did. Some folks were complaining that they were not getting their medication, they couldn't feel their medication, and as a result of that, then there's been a change in the policies that we do actually let the patients put the MDI in their mouth. With the bland aerosol, there it is. It's sterile water or an isotonic solution. That's your normal saline. It's delivered by your large volume nebulizers, and this is a representation of a large volume nebulizer. It has a dis outlet that we can attach to the flow meter. It has that variable air entrainment port. Remember that air entrainment port is how we set the FiO2 we're going to deliver to the patient. It has a jet orifice at this particular point. That's part of our entrainment. You have an outlet port. This is what's going to be delivered to the patient. If you see that outlet port, it's much bigger than it is on the humidifiers. And the reason is we're going to connect the large blue bore tubing to it. You still have capillary tubes in these things. This is what they call a siphon tube because you have to bring that water up in order for it to be acted upon by the gas. There is a water reservoir and there is a filter or diffuser also in there on occasions. More of a filter at this particular point. So why do we use these, or where can we use these? We can use these in the upper airway. If you remember with peds, Trish talked about croup and epiglottitis. This is an upper airway process, and what we need to do is to reduce the swelling that's going on in the upper airways. So we can provide a cool, what we call a cool mist. We'll talk a little bit about that on the next slide, but we're delivering this bland aerosol to the upper airway. We also can use these for our bypassed upper airways. One of the things we need to keep in mind is not everybody who has a bypassed airway, upper airway, is on a mechanical ventilator. You may have run into folks or talked to folks who have had tracheotomies and they still have that open trach at that particular point, and they still have that bypassed upper airway, and they're still going to have some issues with being able to moisturize it and get the secretions out. You probably remember from A&P, hypertonic, hypotonic solutions. Remember, a normal saline is like 0.9% of salt and water. A hypertonic is any solution greater than that 0.9% that we have with the normal saline. It's a fairly salty solution. And then the hypotonic is less than that. We have some hypotonic solutions that are 0.45% at that point, and it's much, much less salty. So the question is then is why do we use any of these? We can use an isotonic, hypertonic, or a hypotonic solution to try to induce coughing in our patients and try to produce a sputum sample. When we give a hypertonic or hypotonic solution to the patient, very irritating. And these patients a lot of times will start coughing, which is what we'd like them to do. On occasions, though, they may start wheezing, and I'm going to address that in just a moment here. So what we do with these patients before we start any of these solutions on them is we're going to ask the patient, are you coughing anything up? And can you cough? So if the patient tells me I have a lot of secretions and I've been coughing them out, that's what finally brought me here to the doc, then we know that perhaps we don't need to give this solution to the patient, that we can ask them to go ahead and cough for us and to give us a sputum sample. So what we normally do is we bring our sterile sputum cup with us. We're going to ask the patient, please rinse your mouth out. In some cases, you might ask them to, if they've eaten something, can you just brush your teeth really, really quick for us if they have a toothbrush? If not, they do definitely need to rinse their mouth out. What we're trying to do is we're trying to remove the sputum you get in your mouth at that particular point. So we need them to do that. And then we're going to tell them, starting with your toes, work a cough up. And when you feel that cough coming out and you can feel the mucus coming up, we'll give them the sterile cup and have them go ahead and put their sputum sample inside of it. They can hold the cup. If they can't, then we'll hold the cup for them. They cannot put their fingers inside of it. They can't, use it to pull the sputum off their lip if it's really, really thick or anything. Definitely they can't use it to pull it off the blankets or the sheets or their gowns either. If they can't do that, then we may have to use that isotonic, hypertonic, or hypotonic solution. And if that's what we're doing, we need to be there with them, because if these people are starting to cough, sometimes they'll also start to wheeze, and they'll have an increased airway resistance and increased work of breathing. If that is happening, then what we need to do for that patient at that point is to say, we're going to stop this treatment, and if we have an order for albuterol or another bronchodilator, we'll go ahead and administer it at that point, because we need to get the airways more relaxed. Sometimes if that happens, we can also get the sputum sample once we relax the airways a little bit as far as that goes. But first and foremost, and you're going to hear this again when we talk about suctioning and trach care, you need to ask the patient, can you cough? Can you give me a sputum sample? So in this case, we're going to talk a little bit about a cool aerosol. If you look at the picture, you can see there's a person who has a large volume nebulizer hooked up to his oxygen flow meter. You can also see that he has large bore tubing in line. In the center of the large bore tubing, you can see a little portion there. That is your drain bag. Whenever we set up an aerosol on a patient, we need to have a drain bag, because remember that gas is being cooled as it goes through the cool room. As a result of that, we're having the condensation and the rain out of the water from that large volume nebulizer. In this case, this patient has a trach mask on, and it's covering over his trach and providing the cool aerosol for him. So why do we use a cool mist? Well, basically, one is for upper airway edema. This is where you have, and if you see number 3 on the list, laryngeal tracheal bronchitis, this is your croup. We're trying to reduce the swelling from the croup at that point. If there's a vasoconstriction going on, if there's stridor, if you can hear stridor, that's also swelling in that airway, and we need to be able to relax the airways. Subglottic edema, post-extubation edema, hoarseness is another one. It could be that somebody has something in their upper airway, and we need to relax it so they can cough it out and then be able to communicate much better. And then any postoperative care of the upper airway that we have, patients who have had surgery, who've smoked and have cancer of the larynx or something along that line, we do have to give them some cool aerosols to be able to reduce the swelling so that they can keep on breathing. Another type of aerosol we can use would be the same device. It would be a heated aerosol. So with this large volume nebulizer, a lot of them come with their own heaters. We call them donut heaters because they look like donuts. And we just go ahead and put that on there and we'll plug it in. The thing about most of the donut heaters that I've seen, they don't have a temperature control. You just basically put it on the nebulizer, plug it in, and let it run. So what do we have to do if we're going to do this? Remember when we talked about humidity, you have to have a thermometer, and the thermometer has to be proximal to the patient. And that's how we go ahead and watch the temperature at that point, because we don't want this patient getting burned by the aerosols we're delivering. We can also use it to increase the amount of humidity we're offering for these patients. In this case, if we're not doing very much with this patient except watching their oxygen, maybe giving them breathing treatments that we'll do with our small volume nebulizers or our MDIs or DPIs, then we can also use this then to produce more humidity for this patient to help them cough out their secretions and keep the airway open. This will also help resolve the humidity deficit at this particular point. Do we always use heated aerosols? No. Do we always use cool aerosols? No. A lot of it depends on what's wrong with the patient and what we're trying to do with this patient. One of the problems with cool aerosols, it sometimes causes bronchoconstriction, a little bronchospasm. We definitely have to be careful when we're doing this so that we don't cause problems with the patient. If you remember watching TV on occasions, especially during the wintertime, if there's a great big snowstorm going on or it's really, really cold, they'll talk to these people and ask them, how are you doing? How are you coping with this? And a lot of them have scarves on. And the reason they have the scarves on is they're protecting their airway. That cold aerosol would cause that bronchoconstriction, and it could also lead to bronchospasms. And so they're just rebreathing the heat and moisture they're putting out to keep that airway open and not have that problem. So some of the contraindications, hazards, or complications of bland aerosol or bronchoconstriction, bronchospasm, and these are major, major contraindications. If your patient tells you every time I get a cool mist, I immediately start coughing, I start to have wheezing, I start to have stridor, at that point in time, the last thing we need to set up on that patient is a cool mist. We need to give them some warmth. We need to watch for side effects. And the side effects would be the stridor, the wheezing, and the increased airway resistance and the increased work of breathing. So we need to make sure we're doing a good patient assessment on these patients. If we're not, then unfortunately we may miss the problems when they start. Something else we need to watch for, wheezing or bronchospasm again, infection. Remember, anything that carries water with it carries the risk of infection. And if you remember, the number one germ that we have to watch out for is Pseudomonas at this particular point. Overhydration, the question comes up is how can you overhydrate a patient or overhydrate anything that you're doing with these patients? Well, if you go back and think about humidity, when we heat humidity and raise the temperature of the gas, if we don't watch it, that temperature can go up way too high, at which point in time now we're delivering too much humidity to this patient and we're going to overhydrate their secretions. A sad story someone once told me. They were in school. They had a friend of theirs who used to panic whenever they had a test or anything. She would start wheezing and she'd start having difficulty with her breathing. Apparently they were having a test one day. The next day she was starting to do that, and she went in and she said, I'm going to go take a shower, told her parents that. She used to like to take hot showers, which is one thing you don't want to do. That's immediate overhydration at that particular point. Unfortunately, about 45 minutes later, they found her in the shower. She had actually used up in her inhaler, and the shower had been hot, and she had occluded her airways with mucus plugging. So we need to make sure that we watch this. This is something else too. When we used to do cardiac rehab and work with the cardiac patients, when it was time for them to have a shower, the cardiologist would tell them, you cannot take a hot shower. It has to be lukewarm, no more than that. Patient discomfort, excuse me. Patient discomfort can be because of the bronchoconstriction, the bronchospasm, the fact that the patient is not comfortable with this, that we've increased their work of breathing and their airway resistance. So we have to watch that also. Caregiver exposure is something that we're still dealing with. At one time, this was probably 10 years ago, the FDA had come out and basically said we need to reduce the amount of caregiver exposure. A lot of people who work in respiratory have asthma. Sometimes they may have cystic fibrosis. They may have something else that's going on with their lungs. And they're being exposed to the medications that they have to take. And if you have an overexposure, remember you can build up tolerance to it, or you can have tachyphylaxis if this just happens to be the wrong time in the wrong place and the wrong day. So one of the things they were trying to do was they were trying to tell the manufacturers, with your nebulizers, your small volume nebulizers, you want to make sure that the patient has the majority of the medication and that we're not seeing a lot of caregiver exposure. Some of your manufacturers have come out with small volume nebulizers. They're fairly self-contained. Not all of them have, and the FDA hasn't really come out and said that they have to do it. I think somewhere along the line we're going to start to see that, and they are going to mandate it at that particular point. So when we're using nebulizers or aerosols for our patients, like I mentioned, you have to do a good patient assessment. Remember, you're going to have to do the vital signs. You want to know what their respiratory rate is. You want to know what their heart rate is. On occasions, you need to know what their blood pressure is. You definitely need to know what are their breath sounds? Are they wheezing? Are they having bronchoconstriction? Do they have stridor? So all the things that you learned in patient assessment, or this is what you're going to put at the use at this particular point. And then we need to make sure that we talk to these patients. We need to ask them, basic questions. How are you feeling? Have you ever done this before? This is what we're going to do. Here's what we're expecting to happen with this. If you have a question, let me know. Now, one thing I like to stress with students, and I stressed with therapists, is you have to be careful what you say to that patient and how you say it. If you're doing something with that patient, for example, you go in and tell them, we're going to give you a breathing treatment. Have you ever taken one of these before? Patient goes, no. I'm a little concerned because I've heard really horror stories about them, that they cause people to wheeze and that they can't breathe sometimes. You don't want to sit there and go, yeah, that's very, very true. That does happen. And, a lot of these patients have really bad outcomes because one thing you're going to find out is the patient is not going to do what you need them to do. Are you going to tell them a fib and say, oh, that never happens? No, you're not going to do that either because they know that you're not being completely honest with them. What you need to basically tell them is, some people do have reactions to it. We are here with you. If we see anything that would be a reaction, we will stop this treatment immediately. If that in fact does happen, we'll talk to your physician. Right now, though, you need whatever we're doing to be able to help you breathe and breathe better at this point. So after we do this, and we're going to watch the patient while they're doing these treatments, we're going to look and see, has their work of breathing has decreased. If their work of breathing has decreased, for the most part, they also have decreased airway resistance. We want to see if their heart rate is going to be better. Has it come down? If it was very high, their respiratory rate, has it fallen back into the normal range? Are they no longer using accessory muscles? Are they, look much less stressed, much more comfortable at that particular point? And we can ask them at the end of this treatment, how do you feel? And a lot of your patients are very honest with you. I feel so much better. These treatments work out really well for me. I'm glad that you came here so I know what's going on with it. If we have to do an ABG, I should see a better PaO2. I should see a decrease in my CO2, and hopefully my pH will stay within its normal acid-base balance. If I'm doing pulse oximetry, I want to make sure my SpO2 is much better also for this patient. If we need to go ahead and get a sputum sample, then we're also going to ask them to do that. You have patients out there, you see this sometimes, and we see it more often with our female patients and our people of age patients. You'll ask them, can you go ahead and spit into this cup or put the sample in this cup? And they'll tell you things like, oh no, when I was growing up, my mom told me, you can't spit, you're a lady. Okay. Well, can we just sort of ignore mom's advice this time? Because I really need this sample. I'm not really sure I can do that. I can probably put it in this Kleenex over here and just give you the Kleenex if it helps. And that unfortunately is not going to help. We see this and people sometimes go, that is really gross, is that they'll cough and they've coughed something up, but instead of spitting it out, they'll go ahead and swallow it. So, you just have to work with these patients and tell them, it's okay, mom is not going to punish you if you spit into the cup for me. When we get sputum samples, if you remember when we talked about humidifiers and we have to fill them up, especially our heated humidifiers, I told you if you have a bottle of sterile water, it has to have the date, the time, and your initials on it. With your sputum sample, guess what? You have to label it with the patient's name. Make sure that you can grab one of the labels, the room they're in, the date, the time, your initials, and why are you sending it down to the lab to be cultured? What culture and sensitivity means is we're going to see what grows on that sample that you gave us. Sensitivity is if we're giving you an antibiotic, is it working? Is this antibiotic effective? So when we label this label, one of the things that you put on this label, and you'll learn this and you'll see this, is you're going to put a C, the upper 7, which is the ampersand, and S. That's C and S for culture and sensitivity. If you do not label these samples, the lab will throw them away and you're going to have to start all over again. So make sure you label them and put your initials on them. Sometimes they'll call back and say, can you tell me who, in my case it was LF is, and they go, yeah, that's Louise, and then they can call me if there's a problem or something. Now, one thing with the sputum, and we're going to talk about this again, you don't have to fill up the entire sputum jar. Sometimes you just need a very small amount that you can use. So, you don't have to stand in there for an hour and have that patient continuously cough. So we want to know, how's this patient doing? Do they have any pain, any shortness of breath? There are patients who do breathing treatments and they will tell you, every time I do one of these, I get a little bit more winded. However, after about 20 or 30 minutes, I'm able to breathe much better. So I don't want to stop this treatment. I need to keep it up, okay? And if that's what they're going to do, we're going to monitor them and watch them, and we will let them do that. Once we're finished in reassessing them, because at the end of the treatment, we're also going to reassess them. We assess before, we reassess after. If we see something going on in the middle of the treatment, we're going to reassess them also. We need to know what's actually going on with these patients. If we leave, we're not going to spend a half an hour in the room to see if this patient is actually doing better, but we will check on them until we feel comfortable with them. We're going to look at the heart rate and the rhythm. If you have a patient and you're giving them a treatment, it could be for a sputum sample, and all of a sudden their heart rate goes from 80 beats per minute to 140 beats per minute. There's a slight issue here. And so what we need to do is stop that treatment and ask them, is this something that normally happens if you do these treatments? Oh yeah, it's not a big deal. I just go ahead and do it. Yeah, it'll catch up eventually and I'll feel much, much better at this particular point. If their rhythm changes, also watch that too. There was a time that we had a patient in our intensive care unit. We had given him some breathing patterns and his rhythm changed. He became asystolic. So they had to do CPR on him, and that was probably the last treatment he got. We can also do the blood pressure. Sometimes our patients have blood pressure cuffs on them, and then we can watch and see what's happening with their blood pressure, the respiratory rate, and the pattern. If they were breathing, say, 14 times a minute, and now they're breathing 28 times a minute, there's an issue here. The issue in this case can be, and it's always interesting dealing with patients, is that they will start to hyperventilate when you give them the breathing treatment. And what you ask them is, why are you doing that? And they'll tell you, well, the faster I breathe, the faster I'll get it done, and then I don't have to do it anymore. Unfortunately, the faster you do it, the faster you get it done, the less effective the treatment's going to be. So we need to talk with them and tell them, there's no prize for first place. You need to slow it down a bit. We want to listen to breath sounds. One of the things I'm going to tell you here, and please remember this, wheezing isn't always bad. Patients who have COPD, patients who have asthma, they have a tendency of wheezing quite a bit. Sometimes what we're listening for with those wheezes are not the tight wheezes that we have when you're in the middle of an exacerbation. We're listening for louder wheezing. We're listening for a better wheeze at that point. The patients will sometimes tell you, I wheeze all the time. This is a really good wheezing for me. And we're going to sit there and go, okay, make a mental note of that. When you chart, you're going to make sure you chart that also, that the patient was wheezing, that they had increased wheezing, or they had increased aeration. Patients stated they breathe like this all the time and always have a lot of wheezing going on, but they feel much, much better at this point. Sputum production. Did they have an effective or ineffective cough? Were they able to cough something out? If your patient is able to cough something out, what we want to do is look at it. For some folks, they'll go, oh, I'm never going to be a therapist because I can't look at sputum. Yes, you can. What we're going to look for, we want to look and see the color of it. Color varies with the type of microbe that's growing in it. Does it have a smell to it or an odor? And if they do have an odor, what kind would you describe it? Very pungent, very fetid. What does it smell like? What is the viscosity of it? Is it thick? If it's really, really thick, is it very tenacious? If you were to put it in your hand, can you pull it apart? Can you build a city with it? Or is it extremely watery? If it's extremely watery, how much difficulty is the patient having getting this out? And we need to watch it because maybe we're giving a medication where we're contributing to that, and we need to stop that medication. And then we want to know how much, okay? How much did the patient cough out? We used to go teaspoons, milliliters, all that other stuff. Now what we look at is a very tiny amount. Is it a small amount? Is it something you would consider a nice amount or in the middle of the road? Or is there a lot of it? Did it fill up the sputum container at that point? Everybody has their own definition of this. Just be aware that we're not going to say, well, it was two teaspoons worth. Yeah, teaspoons vary also. And then we're going to take a look at pulse oximetry. Have they gotten better at this particular point? If they have gotten better, then we have done something good. At the end of all our aerosol treatments, the one thing you have to ask this patient to do is cough. You've just relaxed the airways. You need to make sure they can cough. Sometimes they have a dry cough. Sometimes these patients are going to tell you they're not coughing anything up, and they never cough anything up, and that is okay. That is not a problem, but you still have to have them cough. The number one mistake students make is they don't have their patients cough. So for secretion removal, we just talked about using a bland aerosol. Remember we talked about the fact you can use an isotonic, hypertonic, or hypotonic to remove secretions. We do this, however, we also know that it doesn't work sometimes. That all we do is irritate the airways and run into different issues at this point. So the best thing for us to do is give this patient some humidity or have this patient drink. The nice thing is, and patients will tell you this, when I wake up in the morning, I have that first cup of coffee, and then I'll start to cough, and all this stuff comes out, and they won't give me coffee. I can't get it out. The heat of the coffee, the heat of the water is what's loosening up those secretions and helping them cough it out. So you can always check with the nurse, can they have coffee? If they can, how much can they have? Just bring it to them. If they use sugar, see if they can have it. If they can't, don't bring them sugar. If sometimes they'll have creamers, you can ask the nurse, can they have creamers? If they can, maybe you can bring a creamer to them. But go ahead and provide humidity to those airways because it does help to go ahead and have that patient cough. Okay. So remember too, though, with some of the problems with humidification and even with our nebulizers, we have temperature deviations. The gas is affected by the room temperature, and remember we get rain out in our tubing or our circuits. It can be irritating and cause bronchoconstriction. If we know that's happening, we're going to have to heat a large volume nebulizer if we can do it. Unfortunately, if a patient is on a simple mask, a nasal cannula, we cannot heat those humidifiers. They're not designed for that. They actually will melt down and produce cyanide gas, and that's not something you want to happen. What do we do then? We just basically try to raise the temperature in the room if that's what we need to do. Cross-contamination is another one. If you take your large volume nebulizer off and change devices, or the humidifier off, change devices and things like that, don't leave that sitting in the room and 2 days later, 3 days later, pick it up. You have contamination at this point, so you do have to be careful with that. So for medication delivery, we can do this again for upper airway edema and inflammation, croup, stridor, things that we can take care of. The most common medications we use for this are going to be your epinephrine, because remember, epi has an alpha property to it, and that causes vasoconstriction. We're trying to get those airways closed down. The swelling is so bad that these patients can't breathe. The other thing we can do for patients who have croup or stridor is sometimes we can deliver steroids to them. Steroids are anti-inflammatory, and so we can give them some of those and try to reduce the inflammation. We could also use a cool mist for this too. The coolness of the mist will also help to cause some vasoconstriction at this particular point. At one time, what they used to tell us was, if your patient has croup or epiglottitis, take them into the bathroom, turn on the shower really hot, let them breathe in that hot, moist air. When you hear that, you go, I think there's a slight problem here. Remember, anything that's hot is going to cause swelling. Probably maybe 15 years ago, a little bit longer, they came out and said, forget that. It has to be cool. We said, yes, you are correct. We can give an aerosol for relief of allergy or infection. This relief can be both in the upper airways and in the lower airways. Epi is a good one because it also has the beta 1, beta 2 properties. So we're going to use it for its alpha and really your beta 2 properties. If you have Pseudomonas, we're going to give you something like tobramycin. Remember, that's an antibiotic. And we can give tobramycin by small volume nebulizer. We also then medicate the lower airway. And the reason we do that is because we can get the medication down there. And we're going to talk about the particles, because particles and where they deposit or how deep they penetrate are going to determine how much medication we're going to get into the lower airways. Question is then, why do we use aerosol therapy? And if you look on the slide here, it talks about it has a rapid onset. Remember, medications have a peak time when they're going to become effective. They do have times when they do onset. If you remember with epinephrine, the onset was within about a minute or so. When we look at albuterol, levoalbuterol, the onset is about 15 minutes. We're going to get these onsets much quicker than if we give it by IV. In some cases, definitely much quicker than if we use tablets. Okay? It's less toxic. We don't have to give you too much of it. If it makes it toxic, one of the side effects, if you remember from pharmacology of the bronchodilators, is that it causes bronchoconstriction. So we can give you a lesser amount of this and be able to make sure that you have good results with it. Unfortunately, it has fewer side effects. You will get some of this medication in systemic circulation. There's no way to avoid it. The majority, though, is staying where we need it, which is in the lower airways. It's going to cause that bronchodilation. It's going to relax those airways for us so that the patient can breathe much better. And again, if they have to give us a sputum sample, it may even help us at that point. So we talk about particles. Particles, remember, are aerosols, and that's your definition of aerosols. And so when we talk about medications, one of the things we need to know is, where's this aerosol going to be delivered? Is it going to the upper airway? Is it going to the lower airway? Or is it going to both of them? And so as a result of that, we need to know what size is this particle going to be. If I want to deliver something to the lower airway, and if you look on the slide here, you'll see anything greater than 100 microns doesn't enter the respiratory tract. It rains out from 10 to 100 in the mouth or 5 to 100 in the nose. So if someone comes to you and says, we're going to come up with this new medication, the average particle size is 6 microns. And you're sitting there going, where's this medication supposed to work? In the lower airway. That is not a good medication. The particles are way too big. You can look in the PDR and it tells you sometimes what the particle sizes are. If you talk to the drug manufacturers, you can ask them what size are your particles because we need to know that information. Your book is going to talk about two things. It's going to talk about MMAD, which is mass medium aerodynamic diameter. That is looking at the particle sizes and determining what is the average particle size. And how they do this is they have to count the particles coming out of that aerosol. It used to be that they would capture it and then they would go ahead and put it under a microscope and you had to count them. Now we have the electron microscope that helps us with that. That tells us then what is the average size of that particle. If this is something going to the lower airways and your manufacturer says it is for the lower airways and the MMAD is 3 microns, what he is telling you is that half of the particles are greater than 3 microns, the other half of the particles are less than 3 microns. Is this a good medication? Well, it's going to depend, and what it's going to depend on is something we call GSD, or geometric scatter dispersal, or along that line. I'll get you a better definition of it. But basically what it does is it's a bell curve. Some of you guys may have taken that when you took math in high school or college. Remember, in the bell curve, the center portion, 85% of your particles are in there. And then as you move out, you get 1 standard deviation on both sides, 2 standard deviations on both sides. So what we look at is we look at what is the mean particle size, and then we look for the distribution of those particles. If 85% of them are in the center, then that basically means that 85% of the particles are somewhere less than or greater than 3 microns. Then we can look out at the standard deviations and see how many particles fall into these standard deviation. And then we can take a look at those, and that tells us how many particles are going to be effective for us. Now that we've finished that, that is interesting. So in order to get the particles that we want down into the lower airway, they have to be somewhere between 1 to 5 microns. You can see the 2 to 5 microns are going to settle out in the bronchi and the bronchioles. The 1 to 2 microns will settle out in the alveoli. And as a result of that, then, we need to know how many of these particles fall in these ranges. You can see anything less than 1 micron is way too stable. And as a result of being way too stable, it doesn't deposit. Remember, particles are in constant motion, random motion. And so although we have them in the airway, they're continuing to move and run into each other and will not settle out. When we talk about how do we teach patients to breathe so that they can get the most of their medication, we're going to talk about a breath hold. And the question is why do we have our patients hold their breath after they take an inhalation? It's because we're hoping that those particles will run into each other, and if they do, that for a small period of time, that they'll form a particle size greater than the 1 micron, and that in fact they will fall out of suspension and fall into the airways to be delivered. So these are 2 pictures, and this tells you a little bit about how the medication rains out. As you can see on here, the nose, 10 microns are removed. In the mouth, 15 microns are removed. 5 to 10 in the first 6 generations. And then when we get into the lower airway, now we're talking 1 to 5 microns. And then the other picture is also showing the same thing, showing the different sizes of micron and where they settle out. So particle size depends. There's my geometric standard deviation. Okay. What do we know about the equipment that we're giving our medications in? Medications have a density, they have a weight, they're a particle. And so when we're giving medications to our patients, we need to make sure that the weight of the medication can be handled by the device that we're using. And right now I'll use a small volume nebulizer. If I have a small volume nebulizer and a medication that I don't know what the sizes are and whether or not it's going to work because I haven't read the literature, or the person who's selling it hasn't come talk to us, or they ignored us and never answered that question for us, then I don't know, is this patient going to get the medication in the time that they need it, or is it going to be gone before they have a chance to really have it react for them at that point. So we need to know that our equipment and the weight of the aerosol match. And we have different nebulizers. If you remember, again, back in pharmacology, they talked a little bit about the Perry nebulizer, and then we use that for pentamidine and things along that line. Those nebulizers are made for that type of drug. Do they work with our small volume nebulizers? Yes, they do, because the drug is not too heavy or too light for it. So when we're looking at equipment, if we're the ones who are going to recommend equipment, we need to know, is this equipment going to actually match the aerosol, or is the aerosol going to go ahead and match what's going on with our patients? This is a heterodisperse, which is different from either a homeo or a monodisperse. Heterodisperse means you have different sizes of particles. So remember we talked about which the next one is your MMAD, the mass medium aerodynamic diameter, tells us what the mean particle size is. And because of that mean particle size, we have particles that are larger, we have particles that are smaller. And as a result of that, we have the heterodisperse at this point. Right now, I cannot think of any piece of equipment that we've used that gives us that type of a dispersal. Most of the equipment, say all to a certain case, have the heterodisperse. And it's not a problem because it works what we need to do the things we need to do. And then again, with the geometric standard deviation, or the GSD, we need to know how many particles are within that range that we're using at that particular point. And as long as they have a good distribution, then we know that things are going to work well for us, okay? We also know, based on the particle size, how deep is it going to travel. If you're trying to get a medication for the lower airways, the average size, again, is 6 microns. We know that 50% of the microns are greater than 6, 50% of the microns are less than 6. Even though the distribution looks fairly decent, it could be that those particles are still too big. Say the particles that range out between 3 and 9 microns. Well, we can just toss away anything above 5 microns because it's not going to hit the lower airways. Then how much is below 5 microns in that 3 to 5 micron range? And then we can say, okay, so how many of them are going to get down to the bases of the lower airways? And the answer is none. If you remember the lower airways, the effective particle sizes are 1 to 2 microns, so that medication will never reach down there. It's going to stay up in the bronchus or the bronchi. So we look at deposition, how deep does it travel and where does it settle in? And there's some different things that affect it. And one is inertial impaction, and I have a couple of slides coming up. Inertial impaction basically means this. The aerosol deposit will deposit on the back of the throat. The reason the particle will settle on the back of the throat is when you inhale it, it's too big to make the turn and go down into the trachea and then down into the airway. So depending on how fast you breathe, you can put a lot of these particles on the back of your throat and decrease the amount that are actually settling into the airways. If you breathe too slowly, it's just going to deposit in your mouth. You're not going to get them out. But inertial impaction is something that we definitely need to watch. It's interesting with this concept because sometimes your patients will tell you these medications aren't working if I don't feel them on the back of my throat. That's why I do what I do to be able to breathe and get a good result from them. Sedimentation or gravity is basically what is the size of the particle, where is it going to fall out of suspension. Again, that also depends on what's the size of the particle at that point. Stability, Brownian movement, we can put these two together. Stability and Brownian movement. Brownian movement, for the most part, is the random movement of small particles. How are they stable? If they're too small, they're less than 1 micron, they are stable and they're going to stay in suspension. And what's going to happen is they're not going to rain out into the airways where we want them to be. Kinetic energy, again, this is where all the particles are in constant movement. And as a result of this constant movement, they're constantly running into each other. And this is part of the principle we try to use to allow more medication to settle out. Temperature and humidity are a big one. If your medication is cold, your deposition is going to be much higher because the particles are going to move much slower at that point. So we need to, if you're going to, especially with your aerosols, your MDIs, your DPIs, you don't want to store your medication in the freezer because before you can take it, you need to warm it up. Otherwise, you're not going to get the medication you need. Humidity can cause those particles to swell, and as a result of that, now you can't get them out, and now they're too big, and if you do get the particles out, they're going to deposit much higher at that particular point. If you remember, people will tell you, the doctors, pharmacists, and everything, do not store your medication in the bathroom. It's affected by the humidity in the bathroom at that point. And then the particle characteristics, we're going to talk about those again. Size is important. You know, what size are these particles and where do they need to be? Ventilatory pattern is how are we going to teach these patients to breathe when they're taking their medications. We have different ways of teaching them for the various devices that we use. And sometimes we have a problem when we teach our patients. Patience is always important when working with patients. We talk about doing a breath hold. We do the breath hold because we're waiting for the particles to run into each other, become a larger particle, and rain out. If we don't do that breath hold, especially with our small volume nebulizers, and we don't do it all the time, but with our MDIs, we're going to have a problem because we're not going to get the medication to do what we needed to do at that particular point. So this is a picture, and you can see sedimentation, inertia, and diffusion are in this area. What we see, sedimentation, again, happens with gravity. The size of the particle will be pulled out of suspension and deposit wherever it's going to deposit. Is it going to be in the mouth? Is it going to be in the nose? Is it going to be in the trachea? Inertial impaction, as you can see, here's the particles hitting the back of the airway because they're too big to go and make the turn into the right and left main stem. And then diffusion, this is your Brownian movement. The reason it looks kind of artistic is, remember, those particles are in constant motion, and because of that, they're just moving back and forth. They're hitting the airway, they're hitting each other, they're not settling out because they're way too small. And this is another one that shows you that inertial impaction, what happens with at this particular point. The larger the particles, the higher they settle out. The smaller the particles, we're at least going to get them past the back of the throat, past the trachea, and hopefully into the bronchi. If they're too big, they'll settle out or deposit before that. So when we talk about the deposition and penetration, we're looking at what is the size of the particle, also a little bit what is the speed of the particles that we're delivering at this particular point, where are they going to deposit? Will they deposit in the upper airways? Will they deposit in the lower airways? Where is it? And penetration is basically how do they travel to get where they need to be. And so aerosol clearance, how do we get through with these? Remember, you have your type 3 cells, which is a good question. What are the type 3 cells in your lungs? Remember, too, you have microvilli that are going to help move this, and we can use this. Okay, so the primary mechanism for removing aerosols is by your mucociliary escalator. It's going to remove whatever's in the airways up. Coughing, that's why coughing is so important. Coughing is your number one protector of your lungs. And so we're going to have these patients give us a good cough. There's your phagocytosis by the type 3 alveolar cells. Rinsing your mouth, especially with steroids. If you remember from pharmacology, we said that the steroid particles are a little bit bigger. As a result of that, they have a tendency of staying in the airways, staying in your mouth, and they will cause secondary infection. They're opportunistic infection makers. Suctioning we're going to talk about because we need to talk about suctioning to remove some particles, and then swallowing. One of the things we try to tell our patients is if you're taking a steroid, do not swallow. Once you swallow, you put it into systemic circulation. If you swallow a lot of the other particles, you're also going to put that into systemic circulation, and we'll see more of the side effects at that particular point. So this is your aerosol introduction. What I'm going to do with this is I'm going to go ahead and give you your outside assignment, your classwork for this. If you have any questions, please email me or call me, and I will try to answer them as best I can.